Hi, thank you all for being here today. My name is Dan Gorenstein. I'm the founder and executive editor of Tradeoffs. If you're new to Tradeoffs, we're a nonprofit news organization that covers healthcare's toughest choices. We produce a weekly podcast called Tradeoffs, which you can get wherever you find your podcasts. There have been a lot of fast and furious changes in healthcare over the last year, as you well know, and it can be hard to make sense of all of this. That's why we've partnered with our friends at the Leonard Institute of Health Economics at the University of Pennsylvania for a series of conversations that we call Decoding the Moment.
And hi, I'm Rachel Warner. I'm the executive director of LDI. LDI is Penn's hub for research on healthcare delivery, health policy, and population health. We bring together more than 500 researchers who are national experts and thought leaders on health and healthcare. We're excited to come together with Tradeoffs to create a place where you all can better understand what's happening in Washington and what it may mean for the future.
Just before New Year's, the Trump administration announced how much money each state would get from the $50 billion Rural Health Transformation Program. This pot of money was created by Congress last year, and the administration invited states to propose how they would use it to improve outcomes, grow the rural healthcare workforce, and drive innovation. Federal officials have been clear. This money is meant to transform rural healthcare, not fill in funding gaps. States were given just 52 days to pull together their applications for this new money.
Half of the money is being split equally across states. Each state will get at least $100 million a year over the next 5 years. The rest of the money will be awarded based on a series of factors, including how rural a state is, what states propose to do with the money, and whether the states adopt policies aligned with the administration's Make America Healthy Again priorities. Large rural states like Texas, Alaska, California, and Montana got the most money in 2026. But some small states like New Jersey, Rhode Island, and Connecticut got significantly more per rural resident.
While supporting rural health has bipartisan support, I mean, every state, right, has some rural corner, there has been a lot of scrutiny over this fund. Democrats and many health policy experts argue that this temporary $50 billion infusion pales in comparison to the some $1 trillion in cuts to Medicaid and Obamacare also passed by Congress last year. Critics also worry about a lack of transparency and whether blue states will get less money because they oppose Trump administration policies. Today, we want to help you push past the partisanship, put this new money for rural health in context, examine the evidence, and consider what's next now that the money is starting to flow. We've asked for your questions in advance, and more than 80 of you have submitted them with your registration. Thank you so much for that. That is super cool. Please talk up the other folks in the chat. We hope that part of what we can do through these events is help you all connect with each other and learn from each other. To instigate that, please jump into the chat now, introduce yourself, and maybe what you are hoping to learn today. While you do that, I'm going to turn it back over to you, Rachel, to kick off this really important, timely conversation with three big numbers that you've put together.
Great, thanks, Dan. So the first number is 80%, which is the percentage of rural America that is designated as medically underserved. And so that means it's a shortage, the area has a shortage of primary care, has high infant mortality rates, poverty rates, or high elderly population. As a result of this, most rural Americans faced significant obstacles in accessing healthcare, contributing to worse health and shorter life expectancies among rural populations compared to those in urban areas. The second number is 44%, or the proportion of rural hospitals operating at a financial loss. Rural hospitals have relatively high fixed costs, such as staffing an emergency room 24/7, but they have low patient volume, so the cost per patient is high. And because of that, and because they care for older adults and poorer patients, rural hospitals have fewer commercially insured patients, relying instead on lower payments from Medicare and Medicaid. In addition, the states that have not expanded Medicaid are disproportionately rural. And so those 10 states have higher rates of uninsured patients and more uncompensated care, which further weakens rural hospitals' financial margins. These hospital finances are important because weak finances can lead to hospital closure. And when a hospital shuts its doors, rural Americans lose access not only to emergency care, but also to essential services like maternity care and cancer treatment. Even before Medicaid changes that are coming, which I will talk about next, rural healthcare has been struggling. And the third number is 1.8 million. That's the number of rural Americans expected to lose Medicaid coverage over the next decade under HR 1. So HR 1, which is also known as the One Big Beautiful Bill Act, is changing Medicaid by imposing work requirements and requiring more frequent eligibility determinations. Both of those are going to make it harder for people to get on Medicaid and stay on Medicaid. The resulting loss of Medicaid coverage will impact both individuals and the healthcare system. For individuals, becoming uninsured leads to foregone care, missed medications, medical debt, and even higher mortality rates among those who lose coverage. For healthcare systems, the higher uninsured rates are a big financial hit, reducing operating margins for hospitals, for primary care providers, and for specialists. The Medicaid changes under HR 1 are likely to exacerbate a rural health crisis that has been years in the making.
Rachel, thank you so much for those numbers. Really appreciate it. Now I'm going to ask our three panelists who are going to impress and dazzle you all over the course of this hour to come off of whatever it is, to come onto video and come off of mute and introduce themselves and tell you a little bit about them. Kevin, let's start with you, please.
Thank you. My name is Kevin Bennett. I am a professor here at the University of South Carolina School of Medicine and Rural Health Fellow with the Commonwealth Fund.
Paula?
Hi, everyone. Thank you so much for being here. My name is Paula Chatterjee. I am an assistant professor at the University of Pennsylvania and a senior fellow at the Leonard Davis Institute. I'm a clinician and a health policy researcher who focuses on the healthcare safety net.
Sarah Jane.
Hi, everyone. It's good to see some friendly sources and people in the chat. It's good to see you guys. I'm Sarah Jane Tribble. I'm the Chief Rural Health Correspondent with KFF Health News here in DC.
Great. Thanks so much. And again, these folks have been covering this issue from different perspectives for quite some time, and you are in store for some really great information. We've had a couple of background calls, prep calls for this, and I know I'm buzzed and jazzed by what these panelists have to say. It's pretty awesome. Okay, so let's just get going quickly here. We're going to go around the horn, lightning style, to kick things off. You've each had some time to dig into the awards from the federal government. What's one word or phrase you would use to describe what you've seen so far? Sarah Jane, let's start with you.
Yeah, actually, I'm going to say wow, because I was on the press call on December 29th, and the time frame that the states are dealing with that have already dealt with, that the Office of Rural Health Transformation that's been created have been dealing with, it's all just so very fast. And what we heard on the press call was that, these applications will be put in place. The states are going to start working, and then there's going to be a review, for the 2027 money by the end of the year. So states really just have months to put these plans in place, get them started and rolling. So, wow.
Great. Paula?
I think my word is mismatch. And this is based on the fact that I've spent the past few weeks trying to dive into these state allocations. We were trying to even do some work before that on predicting where allocations would go because we had a good amount of information about sort of where and how the money was going to be dispersed. And, perhaps I'm a one-trick pony as a clinician, but my interest is money getting to where people have health needs and where, the mortality crisis in rural America is most salient. And I now have evidence, and I think we have growing evidence that perhaps it's not going to get there. And so that's why I think my initial assessment can be summarized by mismatch.
Right. Is money getting to where it needs to go? Seems like a great question. Hopefully we'll have a lot of time to discuss that over the next hour. Kevin, one word.
Yeah. Well, I have a lot of words for it, but the primarily I would say cautious. This is a transformation fund program, but as you said, 50 some days to pull it together. And there are a lot of parameters around this program that make it hard to kind of stick your neck out and be truly innovative. Because if it doesn't work, then future funding is in jeopardy. There's a lot of great things in these proposals, but I think if we really wanted to transform, they would have gone a lot further. And I would imagine folks wanted to go further, but wanted to stick within the parameters of the program to keep it going. So,
Great. I'm hearing collectively through the three of you from your three words, I'm hearing a healthy dose of skepticism is sort of how it sounds going in. Sarah Jane, let's go a layer deeper. Uh, You've been tracking this process for months now, talking to people all around the country. A lot of folks in the audience, including Aaron Pervin, want to know what this money is going to now that the awards are out, right? What trends, I guess, Sarah Jane, are you seeing in terms of what the Trump administration chose to fund here?
Yeah, first of all, I would just say that the law itself created by Congress was very prescriptive, right? So the law itself stated that every state would get an equal amount of money. So you're seeing the first 100 million every state got this year, just given to all 50 states, which for some folks that was a surprise because it had to have an approved application. So first of all 50 states got $100 million, and then they got a certain allotment for their ruralness, and then they got a certain allotment for basically discretionary funding that the administration reviewed the applications and said, yeah, this is a good idea. Now, we have KFF Health News has collected a lot of the applications and posted them online. So we have those applications. What we also know, though, is that the states had to work with CMS. These are competitive grants. So we don't know what's in the end in these grants, but the CMS did put out some, one pagers on what the states are doing. And as far as like trends that we're seeing, workforce was very prescriptive. We saw a lot of states come forth with workforce ideas. We all know that rural areas have a shortage of workforce and have had for a long time. We saw a lot of technology. Of course, this was a transformation program, and states were encouraged to think outside the box. So we're seeing, you know, AI robotics in certain states. We're seeing proposals for hub and spoke plans and telehealth portals and things like that. Big companies that I've written about before, like OnMed, have been lobbying states to get their telehealth booths out there. So tech, workforce. And then the other thing that I was sort of surprised by that I started to notice after the announcements came out, and Dr. Oz mentioned short-term insurance plans or insurance plans in the press call. I think there's a bit of competition set up here. They want competition in the marketplace. They want certificate of needs to disappear, and they want insurance plans that are more open for the market and things like that, scopes of practice expanded. So I'll leave it there, but those were sort of the surprises that I saw, the trends.
Yeah, I appreciate that. And I mean, around this competition, well, excuse me, before we get to the competition, let me look at this. So the whole point of these awards is to transform rural health. And I'd like our panelists to give us an evidence check. Really, how likely are these policies or interventions going to be transformative? Let's start with these workforce initiatives. Policymakers have been trying to get more medical workers into rural areas for decades. This is a longstanding endemic problem. Paula, do we have evidence that shows us what actually works for this?
Great question. As you said, Dan, the rural workforce constellation of challenges has been formidable for decades. And I'll say we've got a reasonable body of evidence to give us sort of moderate confidence about what works. And then, like, there's a bucket of mixed, less effective stuff. So, in terms of this, like, moderate, like, maybe it might work. Rural pipeline programs have some strong evidence. We know that if you recruit folks specifically in the healthcare workforce who come from rural backgrounds, or if you provide people with extended rural training, that is consistently associated with sort of higher rural retention in the workforce. And that's really what we want, right? We want a sustainable workforce that stays in the place. Some education focused strategies, right? Like if you integrate rural placements, rural training pathways in clinical medicine, where I trained, we had, Indian Health Service rotations that folks would go on. And then several of my good friends ended up practicing in the Indian Health Service for their career choice. Offering these training opportunities at really like formidable times can also be important and help with workforce challenges. I'll say that what is less effective, what we have mixed evidence about, is some of these like regulatory incentives, right? These like return of service requirements that can sometimes drive initial recruitment of a workforce, but they often fail to sustain retention after people's obligations under those programs end. And standalone financial incentives of like, hey, we will pay you this much extra money to come work in this place. The evidence for that, I would say, is like weak and inconsistent, especially if you don't combine those types of initiatives with community resources, with educational resources. It's a little bit hard to tell. I'll say that, there's a recent paper that came out by Justin Markowski, Jacob Wallace, and Chima Ndumale in Health Affairs that I find myself coming back to a lot. And this is a program that is like this is a paper that's like a 50-year evaluation of the HPSA program, right? The Health Professional Shortage Area Program. This program was designed to get at this workforce challenge in rural communities from a variety of different levers, right? Loan forgiveness, higher Medicare reimbursements. Like there's a bunch of different stuff that comes under the program. They do this 50-year retrospective on the program, which, by the way, costs like $1 billion a year to administer, and they find no significant changes in mortality or physician density. This is dating back from 1970 to 2018, right? Like that's a long time for us to be able to say, hey, like this is a great effort, but perhaps not achieving the outcomes that we had hoped.
And not to put you too much on the spot, Paula, or any of the other panelists, but when it comes to the workforce policies that we're seeing in what has been approved by the administration, are we seeing evidence-based ideas here? Are we seeing ideas that, like these payments that seem to have less evidence that they're that effective? How innovative have we seen? How convincing? How much? I apologize for stuttering over this question. It's after the holidays. I guess what I'm really trying to ask here is, are we seeing things that in these awards that suggest we could see a boon into the workforce?
Let me just jump in and just give a couple of examples that I saw in the one pagers that HHS sent out and that were in some of the applications. Delaware has proposed a 4-year medical school, which is sort of exciting. I don't think they have one. Illinois wants to expand and establish new training and certification programs for like doulas and other kind of folks who are on the ground working, community workers. And that is something that I think, and Paula can check me on this, research has shown has been beneficial. So there are some ideas out there if you start going through what the states are proposing that are thoughtful. And I do think there's probably evidence that some of these would work. But I'm no researcher, but I just wanted to throw out a couple of things I'm seeing in those white pages.
Kevin, thoughts on this?
Yeah, I think from what I've seen, there are, again, cautious. Going back to my word, a lot of the workforce proposals in these are tried and true methods, pipeline development, incentive programs, loan repayment, all of those sorts of things, training in rural, getting from rural, all these things that we know can be effective. But they're not the answer, as we know, because as Paula indicated, we still have a long ways to go as far as keeping workforce there. And I always go back to, let's follow the money. When I teach this course to undergrads who know nothing about healthcare, I'm like, you got to follow the money with this. And when you have, just take medical students, for example, they have a tremendous debt burden when they graduate. It's really difficult for rural kids who tend to be less resources to carry that debt. And then you want them to work in rural where they might earn less. And the way our payment system is set up is very volume based, fee for service. And without tremendous or very innovative ways of changing the payment system, I think we're always going to have this issue of trying to get rural folks to practice in rural. I think there's a tremendous number of providers across provider types that want to practice in rural, that want to serve in rural and go back home. But the finances just don't work out. There are payment models in some of these programs, these proposals, for alternative payment or value-based purchasing. But really, I have colleagues who have worked on this and talked about, we need capacity payments. We need a bolus of money to rural primary care, for example, just to keep your doors open and just maintain services, and then payment on top of that. Without that kind of change, I think we're always going to struggle with recruitment and retention.
But just I want to move on here, but I just one quick follow-up question, just a gut check question for me, Kevin. You live in South Carolina.
Mm-hmm.
Do you think, what's your gut? Will this focus of the on rural health transformation, will it result in putting a dent in the workforce problem or not really much? We're talking
Um,
at really at the margins or actually a small dent.
yeah, I think it depends on how you define workforce. I think the hardest issue is physicians. And in our state, we have a lot of trouble with OBGYNs and access to that. I don't think that's uncommon anywhere. I think these types of programs could make a large dent and improvement with workforce such as community health workers, doulas that I think Sarah Jane or Paula mentioned earlier. Kind of these wraparound provider types that do tremendous work that improve outcomes and deliver great care to supplement what physicians are able or unable to do because of location and payment. Um, and I think that's the key is how do we pay for CHWs in this type of environment? And value-based could get us to that point, and that would be very valuable. But it's
Very,
it's going to be it's going to take some time.
very good. Thank you. Appreciate this. So again, still in this kind of like cone of evidence checking, I'd like to talk about some of these pro-competition policies that Sarah Jane mentioned a couple minutes ago. The administration gave states bonus points if they said they would eliminate certificate of need laws, which require healthcare providers to prove to state regulators that new services or facilities are needed before they can open up shop. They also wanted states to make it easier for providers to practice in multiple states, and for nurse practitioners and physician associates, for example, to do more care without a supervising physician. What does the literature say about whether we should expect from these policy changes anything substantial here, Paula?
Oh, great question. I think maybe I'm a simple girl. Maybe I'll step back for a second and just say, like, what do we mean when we say competition, right? So when we say that we're trying to harness competition, I think conceptually, what we're trying to say is we want patients to have a choice and we want them to have the real ability to act on that choice. And we want markets to have enough participation to generate competition for quality. I think that's what we mean. And I get that the crux of this argument about competition is that a lot of rural markets have only one hospital or a very thin provider supply, meaning that like true competition rarely exists. I think where I start to think about competition in rural markets a little bit differently is that it's more of a geographic monopoly than like a competitive market issue, right? So, like, for example, insurance carriers oftentimes, not always, but will avoid rural markets because of risk, low enrollment, reducing competitive choices for patients, and like raising premiums when you only have a few insurers operating in those markets. So, trying to address these like structural challenges of geography with like traditional market-based incentives is sort of how I'm trying to reconcile those two things in my head. So let me just provide that like little bit of context before like diving into some of these specifics. Um, I get that there are policies in the RHTP that are trying to like unleash new actors into new markets. And that's where I see sort of certificate of need laws fitting in, right? So like CON laws, these require healthcare providers to get state approval before they can build new facilities or expand certain services. And the goal really is to try to limit excess capacity. These were policies that were developed back in the 60s and 70s, and a lot of states still have them in place. And what I'll say is we actually have a good amount of evidence on, what it means to have a CON law, what happens when a CON law is repealed, CON, whatever folks. I'm maybe not totally in my element on my acronyms, but I think my overall sense here about like I'm going to focus on like the causal inference literature on these laws is that in some situations, having these laws in place can reduce the supply of certain types of healthcare facilities, certain types of healthcare services. I'll say that the evidence for this is primarily for technologies and like entry of like imaging modalities into different markets or ambulatory surgical centers. That's really where we see some of these like access changes associated with these laws. To my knowledge, it hasn't been studied for things like, do these laws inhibit the entry of primary care providers? Do they inhibit the entry of substance use care? Do they inhibit the entry of maternity care? Those are the things that like we know rural populations really need access to. So whether like this very narrow literature generalizes to what rural populations have a really high population need for, I'm not sure. I will say that the effects of these certificate of need laws on patient stuff, right? Like quality and mortality is a little bit more ambiguous, right? Like overall, there's a great NBER working paper that just came out last year by Chris Whaley and some folks at Rand that looks at changes in overall mortality associated with like having these laws and not having these laws, and it's a difference in differences study, and they find no change in overall mortality. They might find some changes in like some disease specific outcomes, but it's a little hard to tell for me. Um, so I guess my like TLDR for you, Dan,
Yeah.
is like CON laws maybe affect access for certain clinical technologies, and perhaps for some like surgical procedures. Whether those access challenges extend to other domains of clinical medicine, I don't know. And whether these laws will fundamentally like whether repealing certificate of need laws are going to like really help patient quality and really help patient outcomes, we don't have strong evidence to suggest that it does.
Right. And one other thing, obviously we're talking about workforce. It seems like part of the idea, what the Trump administration is trying to incentivize here is to to grow workforce, right? By addressing scope of practice, making it easier for certain providers who are not physicians to provide care. That seems like a really laudable goal. Is there any reason to think that that's going to are we seeing, maybe to you, Sarah Jane, are we seeing a serious effort here on the part of states in what has been funded to like really try to go after this?
I mean,
Because we know historically physicians have been really hostile to this sort of move.
I don't have the data on how many of these applications included scope of practice changes. I did see a pharmacist, for example, saying that, he was excited that that scope of practice was being expanded. And my sense is, that open competition, it's been a debated topic in many states. Just going back to the CON for a moment, Dr. Oz did say on the call that 36% of states participated in the CON laws in their applications. And when you look at, I think Ryan posted the briefs that CMS put out, they have those state policy action items so you can see which states participated very quickly on that. To answer your question, though, I do think that the idea of transformation that came with this law kind of opened the gates for states to do all of these experiments. So if states have been thinking about it, if their legislators have been debating it, then this maybe gave them the boost that they wanted.
Have anything you want to add here?
Yeah, I mean, especially in that last point, I would agree. I know here in South Carolina, scope of practice has been a hot topic, and I feel like this is going to supercharge that, honestly. And a phrase that I've heard at our state house before is unrestrained supply. And I think a lot of this, you talk about competition, but if you kind of broadly look at these free market concepts that a lot of folks subscribe to, in healthcare, if we can unrestrain the supply of providers, provider types, practice, CON technologies, the theory is that these restraints, these regulations are holding it back. And then you remove those and they'll enter the rural market. As both the other panelists suggested, there's not a lot of great evidence for some of that. There's a lot more larger issues that are restraining that integration into rural communities. But at least I think that's the thinking with some of this. Like, let's open the market wide open and have anybody that wants to participate in their way do that, and let's see what happens.
This larger push for some sort of
Right,
deregulation.
exactly.
Okay, final thing on this evidence is that around is states pushing forward on MAHA-friendly policies. Things like reinstituting the presidential fitness test in schools, putting additional restrictions on SNAP, formerly food stamps, to push people toward healthier food choices, like banning people from buying soda, or if you're from Chicago like me, what we'd call pop, increasing nutrition education for clinicians. Question for you, Kevin and Paula. What's the research say about the likelihood of these policies improving rural health? Kevin?
Yeah, I think that evidence is mixed. I know, that, uh, yeah, okay, we all know eating better is helpful, right? Um, But when you look at folks who are on SNAP, for example, these are folks who are on the margins financially and resource wise. They're in communities that are food deserts for a lot of cases. Dollar General might be their grocery store, and they don't sell fresh fruit and veggies usually. So it's difficult to say, oh, we'll just change this, we'll tweak this. SNAP regulation will change, some nutrition counseling and education, and then all of a sudden people will eat more healthy and then they'll become healthier. That's a small part of it. There are much, much larger issues at play that are holding people's health back. There the allostatic load of stress, if you're worried about making your rent, is much more impactful on health than if you're drinking a soda every day for lunch, right? Um, Stress leads to poor health behavior, smoking, drinking, etc. If you're working two jobs, you don't have time to go to the grocery store and make a healthy meal. You're going to grab McDonald's or some Subway or something that's cheap and easy to try to feed your family. So I think, it's not that any of these things are bad necessarily. I just don't think it'll make a noticeable change in outcomes that we really want to see.
It's not that right. I mean, that the whole idea, right? We keep going to this word transformational. It's not going to
Right,
be transformational, but
right,
also not necessarily harmful, maybe at the margin, a positive.
right. I think the only harm is if we focus too much on these sorts of things that are just chipping away at the edges instead of focusing on some of the more root issues. I'd rather us spend more time on how do we get transportation to rural communities so they can achieve healthcare access. The fitness test, and then we already use tests. We're just going back to one that I think is kind of nostalgic. I still have my presidential fitness patches somewhere in my, attic.
Congratulations.
I mean,
I'm sure you're
yeah.
proud.
But but does that mean that I, don't occasionally drink a Mountain Dew? Of course it does, So but like I said, it's if we focused on the true root causes and the true root issues, I think we'd get much further along and move the needle much further.
And Paula, can you just speak quickly to the nutrition education?
Sure.
You were pretty funny about this during the prep call.
Well, I was reflecting on my own clinical education, and I remember receiving, some nutrition education. I mean, granted, it's like not to the extent that I learned anatomy, for example, but like I do remember um, receiving education about sort of recommended dietary intake, right? Guidelines for fruits and vegetables. Like I learned about micronutrient deficiencies and how they're more common in patients who undergo bariatric surgery or are struggling with alcohol use disorder, right? Like I feel like my nutritional education was also kind of weaved in throughout my understanding of physiology and pathophysiology, right? I learned how diet and exercise can affect outcomes across clinical conditions. And I don't know, I learned how to have conversations with people about the food they eat, right? That's so a part of nutrition education that I think is part of just standard medical education, right? You talk to people about the food they eat, the food that they enjoy, and how they set healthy goals for their intake, right? I will say that as I read through this New York Times article this morning about RFK Jr.'s upcoming changes to the nutritional guidelines. I did not learn about some of those things, right? I did not learn about consuming more red meat. I did not learn about consuming more saturated fats like full fat dairy. I did learn about some of the harms of like ultra processed foods and stuff. But and learn about the harms of alcohol use. But I will say like the evidence on that is even evolving recently. And like not to be the annoying person who returns to science and myopia, but I feel like more broadly, I think that the mission of improving nutritional education for physicians is, of course, a good one, right? Like, I want to be able to counsel patients better on how food and exercise and lifestyle and, that dimension of, care affects their health. Like, I want to be better at that. I'll say that like nutritional epidemiology is like a uniquely hard field of study, right? Like there's measurement error in how we talk to people about food. Like there's confounding and healthy user biases. These causal effects are long. Like if I ate butter in my teenage years, how is that affecting my cardiovascular response? These are just, it's a hard scientific area of inquiry. And so I think that I want to believe in a goal of like precision nutritional education. Heck yeah. Like I would love to benefit from that education and like pass that on to patients. I'm not sure we're there yet in terms of like where the science currently stands.
Paula and Kevin, what I don't need you to respond to this, but just what I'm hearing you guys say as it pertains to these SNAP policies, to nutrition, education for physicians, some of these things sort of sound good and make intuitive sense, but their impact is in question, and their ability to actually be again transformational is highly in doubt, where there are sort of larger questions that require would benefit from greater scrutiny. And this is a little bit of a distraction, is what I kind of hear you guys saying a little bit about these. I
Yeah.
want to zoom out here for a second and say that I've been a healthcare reporter for about 15 years, and this is one of the first times in my career that I've seen such a spotlight and an opportunity for investment in rural health. I know in many states, officials had listening sessions. They asked for evidence-based programs that they should include in their applications to the federal government. At the same time, as we said earlier, states just had 52 days to put these things together. So, like, how thoughtful can you be in 52 days, right? It's a total sprint. Kevin, you were really on the ground in South Carolina, and it's really, really, we're psyched that you're here because it gives, I think, folks in the audience a chance to understand what a bird's eye view of this process looked like, as how thoughtful it was. I'd really love for you to tell us a story, share with us an anecdote of an idea that you pitched to the state
Mhm.
leaders to help us understand how interested or capable folks, at least in South Carolina, were about being able to incorporate evidence-based solutions into their proposals.
Yeah, and I think every state's process was different. You know, in our state, there was a public comment period where people could submit ideas, proposals, concepts to our Health and Human Services Department was the run kind of managing this proposal for the governor's office. I want to say they said there were 600 to 700 submissions given to them for that. They had several stakeholder meetings, in-person meetings with folks like the State Office of Rural Health, myself, my Center for Rural and Primary Healthcare, AHEC, and others, where we had 15 minutes to pitch ideas and concepts to them. So they gathered a lot of info. But I think South Carolina and several other states are sort of like this too, took a different approach with their program and their proposal in the sense of they didn't really propose structured evidence-based programs per se. They proposed a framework by which they would have people once again submit to them proposals within that framework. We expect those to be sometime in January, where we will pitch specific ideas that fit within this framework within the RHTP, evidence-based programs across workforce and technology and networks and things like that, to implement the overall program. So in our state, it feels like it's a little bit more distributed. You know, they want broad participation with programs and organizations across the state. They want them to do what they're already doing, expand what they're doing, those sorts of things. I'm sure that universities and workforce will submit, healthcare organizations will submit. But it's a bit of a contrast to other states that proposed very specific programs. They're going to do A, B, and C, which are evidence-based programs. We're going to fund that. We're going to do it instead of kind of waiting for it to come in. Um, Not sure which one will be better. Maybe somewhere in the middle. I think there's pros and cons to both approaches. And it's going to be really interesting to see how this plays out in South Carolina because, you know, they could open up these calls and get another 600 to 700 proposals and have to wade through that, fund it. And I think Sarah Jane mentioned August, they start the process again for year two. So how quickly can they turn it around? Maybe they can turn it around more quickly because they're distributed out. Maybe we'll find more evidence that way. My only concern is how coordinated all those efforts are going to be. How active is the state going to be in getting these folks together, collaborating with each other, working together? That's going to be the challenge, but I think is very possible.
And Kevin, not to throw you under the, not to, I'm not asking you to throw South Carolina state officials under the bus here. I'm asking you to share your take on what you witnessed.
Mm.
how much in this process, right? Like I hear you saying that in South Carolina, the officials running the process were curious, or at least curious in the sense that
Mhm.
they were putting out, giving folks opportunity to pitch ideas. In your state, how much were people excited about, specifically about evidence-based ideas versus ideas that sound good but lack the evidence? Because we all know, everybody on this call and everybody in the audience knows, in healthcare, there's a lot of good sounding things that lack meaningful evidence.
Yeah, and that was specific to what they asked for. They wanted evidence-based programs. And we were able to, I think we submitted 9 or 10 different evidence-based programs of things we're already doing, like our collaborative health communities. And I don't know what everybody else submitted. I didn't read all 600 or 700 of them, obviously. Don't know how anybody could have in that time period. It's very challenging. But that is what they specifically asked for, were evidence-based programs that are already up and running that needed to be expanded so that could be quickly implemented. And then sustainability was a big piece. How can this be sustained after this 5-year period?
Which is
So,
something that the administration's really sort of
right.
looking for as well, right? That's something that they want. They're looking for sustainability.
Right. And those are all great things. And like I said, this distributed approach, we might be able to achieve that because these are things that are already happening and organizations that are already existing, and you're not having to build new infrastructure as you go. It's just, it'll be interesting to see this next cycle of proposals and awards, subawards that they're calling them, how many of those are truly evidence-based and how many of them are kind of, I don't know, aspirational based on some evidence or, 2 or 3 degrees separation from that. We're going to have all of that, I'm sure.
Sarah Jane, we haven't heard from you in a couple minutes here. I just want to like throw this to you for a quick second here. If you have a sense on how interested states seem to be when it comes to pushing evidence-based ideas rather than good sounding ideas.
Well, look, the proposal, the application, the NOFO, it asks for evidence-based ideas. So states are very interested in it, and that's what they put in their applications across the board. You saw them citing that because that's what was asked for from the administration. And I think there are a lot of people on this call listening, and I just want to acknowledge that, when this was announced, it wasn't announced with the Office of Rural Health at HRSA. And I think a lot of states have been dealing with the Health Resources and Services Administration through series of grants that often require, these states and the grantees to prove that they're showing results. HRSA was not involved in this. Instead, they set up a new Office of Rural Health Transformation and brought some people over from other agencies and brought some new people in. And the people who created this NOFO, who created this application, were very serious about getting results. And they want those results in 5 years, and they want them to be evidence-based. So I just want to place that on the table. And then also note that the Office of Rural Health Transformation is just getting up and running. They're hiring program officers. I want to know how many they're hiring, but they seem to be very engaged in making sure that the states have somebody to talk to at the federal level. So as they go through this process, they have people to ask questions to and to make sure that they're actually providing and resulting, in outcomes here. So I think as we watch this program roll out in the coming months, and if you're a reporter on this call listening, please call your state, see what their scope of work is. I think that it's going to be important for all of us to keep asking, how is the state working with the federal government and making sure they're, bringing outcomes here for the rural residents? And I think it seems that they are setting up parameters to do that. And I just wanted to put that out there.
Thanks very much, Sarah Jane. Really appreciate that context. Very helpful. Paula, we only have 16 minutes left, so we're at there's so many questions. I wish we had like an hour and a half. I'm not sure if our audience feels the same way, but this conversation's been amazing. But I'm just going to ask all of you guys for all of us to, including myself, to be as truncated here as possible, because I want to get to as many of these questions as we can. Paula, you and Rachel Werner have put together some work to quantify how well this program is set up to meet rural health needs. And I want to use your analysis to answer some of the questions that we've gotten from the audience. In particular, we got some questions asking about how this money could help struggling rural hospitals. Stephen Zuckerman and Maxwell Reel, sorry if I mispronounced your name, Maxwell, were curious about this among others. What did your analysis show about hospitals?
Perfect. Yes. Oh man, I think about hospitals all the time. And I guess what I'll say is that to start, I think the RHTP is very clear in that it's not meant to be a bailout for hospitals and their financial circumstances.
Right.
I will juxtapose that next to the rhetoric around the program, which has been quite different, saying that, this program is going to offset almost all of the financial challenges that might be coming down the pike as a result of changes to the Medicaid program and other financial reforms. So I'll just say there's like a de jure RHDP and then a de facto. That being said, I think if one of the goals is to improve rural health access, like wouldn't it be nice if funds were targeted to places that have had greater access challenges? And so Rachel, a wonderful analyst, Eliza McNeil, and I started to take a peek at this. And, we basically looked at states that have lost the greatest share of their rural hospital beds from 2018 to 2023. This included the pandemic, which accelerated a lot of financial pressures for rural hospitals. And we tried to see sort of, did funding get to those places where more rural hospital beds or a greater share of rural hospital beds were lost? And what we can say is that maybe states that have lost a greater share of their rural hospital get a little bit more total funding, but when you adjust for rural population, that potential benefit goes away almost entirely, right? So when you look at like where funding per rural resident goes, which I think is the right measure. Reasonable people can disagree. Some people can say, no, I just care about how much money is going to a state, and the state gets to decide where to allocate it. It doesn't say anywhere that it always has to go to only rural communities, right? States have some flexibility. That's a reasonable point. Again, I'm a simple girl and I only know one trick, which is like, where are rural people having the greatest health challenges? And for me, it makes sense to have like a person-based denominator here. So if you look at where funding per rural resident is going under this program, it's not going to states that have the highest rural mortality rates. It's not going to states that are projected to have the greatest reductions in federal Medicaid spending. It's not going to places that are losing the most hospital beds. The only thing that we have found that is like weekly correlated with where money is going is a state's administrative capacity. And I think this speaks to some of the questions that have been coming up in the chat, which is like there was such a short time frame here. There was a lot asked of states in this very short time frame for a one shot to get at this pool of money. And unless you're a state that has the administrative capacity to do this, it was probably really hard for you to put this together. And so we do see this like weak positive association between where money went per rural resident and sort of what the quality of a state's administrative capacity were. I veered a little bit from hospital beds and went too long, Dan. I'm sorry.
That's okay, Paula. I just want to stick one follow-up here with you. You at the top talked about mismatch. And I'm wondering, like listening to your answer as you talk about this analysis that you and Rachel put together and your other colleagues put together, is that sort of what's informing this word for you, mismatch? Are you basically saying to us like, okay, there's this money, it's out there, but it's not being as targeted as arguably it should be? Is that basically what you're telling us?
That's what we're trying to tell people in the analyses that we're doing. That's the story. We're saying that the Rural Health Transformation Program has these goals. It has clearly stated goals: improve access, improve rural population health, right? Among others. I'm just being parsimonious here. So if we can benchmark those goals to what we know about what the state of the world is in rural communities, can we say that funding is aligned with need or is it not aligned with need? And unfortunately, we're seeing that in a lot of ways, it perhaps is not well aligned with the needs.
Very good.
Right.
Thank you. I want to move on to Medicaid here. It's been 49 minutes and we haven't talked about Medicaid yet. So, and we saw a lot of folks in the audience actually bring Medicaid questions up, particularly these Medicaid cuts that Congress passed at the same time that they passed the Rural Health Fund. Just a refresher for folks, Republicans in Congress added new eligibility requirements and restricted some common levers states use to fund their Medicaid programs. All told, the Congressional Budget Office predicts that the law will cut nearly $900 billion in federal money from Medicaid over the next 10 years and push some 10 million Americans off of their health insurance. Brent Enos, Tammy Luby and Christopher Mallard all want to know how much this new rural health money will be able to fill the gap left by these Medicaid cuts.
Let me just
Who wants
jump
to go?
in here.
Please.
PFF has done an analysis, and it's the best number I could find on this. 137 billion over a decade will be reduced from Medicaid spending in rural America. So 137 billion. This this rural health fund is 50 billion. You can do the math on that one and how much it fills the gaps. But like Paula has said from the beginning of this conversation, this is not meant to fill that. Now, the rhetoric during the debate in July was for sure about
The rhetoric
rural
in
hospitals.
Congress, in Washington.
Right. The rhetoric in Congress in Washington. Susan Collins, Murkowski in Alaska, they all talked about their rural hospitals. And the rhetoric was that this would help address those fears and concerns. That's on the record. Plenty of Republicans said it. But that's not the reality of what was written in the bill. And the administration followed what was written in the bill. It's the law. The law is for transformation. It very much encourages the use of technology, innovation, things that have, are maybe not directly to rural hospitals. And I don't want to quote this number, but I'm going to indicate it because it's in one of my stories. But I think it's a 15, and help me out here, Paula, Kevin, if you remember it. I think it limits the amount that the state can spend on rural hospital operations by 15%. Is that, you're shaking your head, Paula? Okay, great. I got it right. When you have it in a story, you should remember it. But in any case, you can read my stories. But yeah, no, there is a limit. So they're very clear that this is not a rescue plan for rural hospitals. They've said it in the meetings. We've talked about it here. So while it was the rhetoric of Congress, that's it's not meant to fill the gaps there. Instead, it's meant to help rural America overcome whatever deficiencies that people seem to think it has in healthcare in some way. And I think that's a vague challenge. It'll be exciting to watch what happens.
Kevin, Paula, any thoughts about this question about what this $50 billion can mean in the face of the serious looming shortfalls that states are going to be facing?
Yeah, it's going to be a huge challenge. My colleagues at the National Rural Health Association said this program would have been great as a standalone transformational investment program in changing rural healthcare. With the cuts, you've got facilities that are going to be struggling to keep their doors open, and it's really hard to think about transformation if you're trying to keep your doors open and employees employed and patients served. It is also, I think, we're talking about Medicaid and expansion. This bill, the OB3, is very specifically targeted for those expansion states and populations. And, some states like mine, we never expanded Medicaid and we're not hit as hard as others. So I think that's going to be an interesting dynamic as well. Our hospitals are still going to suffer because of this, because that's where those direct payment cuts are going to come into play. But how do you ask a rural hospital to, change your payment program and create a new workforce and train them if they're worried about making payroll next month? Or they might have to cut OB services because it's expensive and to reduce malpractice. And, it's two-sided. And I think we need to explicitly acknowledge that all of this that we're talking about is a part of a political process. This is politically based legislation. It's not necessarily healthcare legislation. It's not planned out by health policy wonks to create a better healthcare system. I think that's the theme for just about every piece of healthcare related legislation in our country for many years. And that's just the nature of it. So I think you have to explicitly acknowledge those things, that this was a kind of a way to bring other Republicans on board to get the legislation passed. And that's the way the game's played. And so now that it's here and now that they're awarded, what can we do with it? What can we maximize with it to try to get something out of it? To stopgap and do something positive with it, at least in the environment that we're in. And that's the best we can do.
Okay. I'm gonna go to this final lightning round as we look to the future. This money has been awarded. In many ways, of course, this is just the beginning of this story. I've asked each panelist to think about what's next for them specifically as they follow this fund. And hopefully it's going to give everybody in the audience a sense of what your next steps could be or may be. Paula, we've got a lot of researchers in the audience, and a few of them, including Aidan Crowley and Eric Crankshaw, asked about the role of researchers and evaluation. What's one study that you are hoping to do on this, and maybe a bonus idea for someone watching to take on?
Oh man, I think I'm like
Short, Paula. Paula, short.
short. You're right. I'm going to stay focused. Sorry. What I will say is I think that there's tremendous opportunity here for a lot of rigorous natural experiments, right? And for the first time in a long time, they're going to be in rural areas, right? And our evidence on natural experiments in rural areas is sparse, if at all, like focused on this very high risk population. So I'm not going to pick a specific thing, but I think following states' implementation of their proposals and figuring out really beautiful experiments, state border comparisons. I think that the opportunity is ripe to do rigorous research here. I will say that we as researchers have been bad I'll say I as a researcher have been bad at considering what are really perennial challenges in rural health research. How do I deal with small denominators? How do I embrace heterogeneity as a feature and not a bug, right? How do I incorporate these features? And so in that sense, I feel like as a research community, we have to like tool up. We have to tool up to like meet this moment that is going to present us with a lot of opportunities to potentially figure out what works, what doesn't, why, and where. So I am nervous but excited for all of it.
Kevin, now that you've seen South Carolina's award, how are you planning to push for this money to make sustainable change in your state? What advice would you have to others on the ground in other states? And again,
Yeah, I think
short here, short.
short, yes. I think what I would love to see is how this enables systems and structures to change or to be built to coordinate care. We've done some of that work already in the state. How do we create larger systems that really can change and transform rural healthcare? Every state's going to do that differently.
Sorry to interrupt you. Just give
Yeah.
me a one sentence specific when you say those words.
Um, referral networks, coordinating councils, bridge organizations. How do you connect clinical services to community resources to improve patient care? And how do you feed back those informational loops to all those providers and patients? That's the opportunity. Some states are going to do it better than others. We need to learn from them and everybody adopt it by the end of the 5-year cycle. And research needs to be done to figure that out.
Cool. Thank you, sir. Sarah, close us out, please. What's one story that you are following as a journalist, and what do you hope other journalists will keep an eye on?
I'll start with the other journalist. If you are, I think that we should all be watching our states. I think that we should be talking to our state offices and don't get focused just on one aspect, but ask those states if they're following their plans and if they're holding the folks who they're giving money to accountable for providing care to their rural residents. And on that note, that's what I'll be following. I'm going to be looking at the federal government, asking them if they are talking to the states, and just kind of following every aspect of this. I've been covering rural health for a number of years now. I grew up in rural America. I'm very interested to see if the outcomes happen they promised in 5 years.
Mm.
What a perfect place to end it. I would just want to thank Kevin, Paula, and Sarah Jane for your contributions. This was amazing. You've been very, very generous with your time and your energy. Really appreciate it very, very much. If folks want to stay connected with Tradeoffs and LDI, and we certainly hope that you do, you can find links on how to do that in the chat. In particular, Tradeoffs has a 2-part podcast series on the Rural Health Transformation Program dropping January 22nd and 29th. We will take you inside one state's 7-week sprint for their share of the rural health funds and the tough choices that they made to make the most of this opportunity. You'll also find a link to a survey that we hope you will take as well, Rachel, I want to toss it back to you for some final thoughts.
Well, I first want to say thank you to all of the panelists. We just lost Paula, but thank you to everyone for the wonderful conversation today. I learned a lot. I think there's a tremendous opportunity here. Looking forward to the evaluations that everyone's asking for to see what happens in the coming year. And thank you, Dan, for the terrific moderation. As Dan said, you will receive a survey. Please fill it out and give us some feedback about what you liked and what you didn't like. And I also want to encourage everyone to join LDI for our next panel. This is a virtual panel, which will be in just 10 days, January 16th, looking at drug pricing in the current administration. So please join us then. And until then, thanks, everyone.
Thanks, everybody.